Gentlemen, I hope you've managed to get the songs out of your head from last night. I certainly haven't. I have a lot of tunes still going on that kept me awake, so hopefully tomorrow will be a better day. So we'll be discussing about whether we can stop the drugs that we use for chronic myeloid leukemia safely. And I think if we work carefully together, then certainly this is possible. I will try and speak more slowly as opposed to yesterday so that you have plenty of opportunity to understand and to have the translator translate. So as you know from the lectures yesterday of discussing first-line therapy, you know that when you are first diagnosed, your doctor will tell you about the milestones of therapy. So for chronic phase, they will talk about optimal response being less than 10% at 3 months, and then eventually less than 0.1% at 12 months, and then an ongoing and deeper response. And after we have discussed all of this, the patient usually says to us, how long do I have to stay on this medication? And we say, you have to take it for the rest of your life. At which point there is extreme horror. It's never a good feeling when the patient hears that this medication needs to be taken daily and on a regular basis, long term. So that is the usual reaction that we get after we finished the consultation. But there are many reasons to stop tyrosine kinase inhibitor therapy. Yesterday we discussed essential reasons, which were that of pregnancy, so you cannot take the drugs during the time of fetal development. If patients have very severe side effects, it's impossible to carry on with the drug. It's impossible to reduce the dose and carry on with the drug if there is a very severe complication. So we always have to interrupt, but we do that for a short period of time. We also have to adjust what drugs we give because of other comorbidities, but we also have to factor in the need of taking daily therapy and the compliance that we know is suboptimal with any long-term therapy, not only cancer therapy. And of course, as Gyura discussed, there is the cost of therapy. But I am lucky, and all my colleagues are lucky, that we don't have to think about the cost. That's something for politicians and governments. All we are trying to think are about the benefit to our patients and how we should tackle side effects and giving a good response. So your doctor really isn't thinking when they see you, how can I reduce the cost of this pill and this medication? We are trying to do our best for our patients. So we know that more than 2,000 patients so far have stopped the drugs, but they have done this in clinical trials. And clinical trials, if you have participated in these, are very exact. You have to come on the day the trial says, you have to take the dose, you have to adjust the medication according to the dose, and it's very, very strict. So when we are discussing the generic drugs, you have to remember that this is not on clinical trial, so the data will always be different because the control about collecting that data and the side effects is very different. But we know that in clinical trials, we have very accurate data for stopping TKIs. Patient perspective about stopping is positive, but they will only want to stop if they feel that it is a safe thing to do so. They don't want all the investment and the hard work that they put into taking the medication and weathering the side effects to be lost, because then they relapse and they need to have either alternative medication or higher doses or the same medication again. So it's a very important point that we balance the risk of stopping against the benefit of stopping. So the very first study that was introduced for stopping was called stopping imatinib in France, which is now called STIM-1. It seems to be considered as a revolution about stopping a tyrosine kinase inhibitor. But as you know from previous lecturers that have come to your meetings, Moshe Talpaz, he will probably tell you that he had already stopped interferon in CML-treated patients. So the concept about stopping is not a new one. And all of our other hematology specialists are very surprised that we never built in a stopping arm in the very first studies when we introduced imatinib, because most studies have a stopping arm. But at that time, we did not know about the drug, we did not know if it was going to be effective, and we didn't know if it was going to affect any other organs in the body. So if we look at the very first study in France, which was done by François-Xavier Mahon, you can see that it was done some years ago now in 100 CML patients in chronic phase. And there was a lot of anxiety about whether patients would lose their response. So they chose patients that had the best response you could possibly give. So this is an undetectable PCR, all zeros on the PCR for at least 2 years. And even if you had 0.001 at any time point, you couldn't go into the study, which was slightly unfair on those patients because for all of you who are zero or know patients who have a zero, you know that the test does fluctuate sometimes. So it's a very optimal responding group. And here, imatinib, 400 milligrams standard dose, was stopped immediately. And for safety, the PCR was done every 4 weeks for 1 year, and then in year 2, every 2 months, and then in year 3, every 3 months. And you can see that after a considerable length of time, this study has also been updated recently, that 40% of the patients are staying off their tyrosine kinase inhibitor therapy, which is excellent and also very surprising considering that we thought that we needed to constantly overcome the BCR-ABL target on a daily basis for a good effect. You can also see that the majority of patients that had their CML come back did so in the first 6 months of treatment. So initially we called that a molecular relapse, you can see here, but the terminology is changing. And because we are talking about quite deep responses, I just want to remind you about the definitions. So we have 3 definitions of complete molecular response shown here. You have 4, 4.5, and 5. So 4 is less than 0.01. 4.5 is less than 0.0032. And CMR5 is obviously very easy because it's all zeros. And that's important because we are talking about very sensitive levels of detection in order to be able to stop treatment and the implications that there are. So the first study looked at patients who had any increase in their BCR-ABL transcripts. But as time went on, the French got slightly more brave and then took the threshold as greater than 0.1%. So that is allowing the patient to lose major molecular response. For those patients who are very deep, that's quite alarming watching the PCR go up to actually lose a major molecular response. But if you do the stopping this way, and only reintroduce the drug when you lose MMR, then 60% of the patients will stay off their treatment, which is even more encouraging. So working on the knowledge that we have from STIM and according to STIM, We then did another European study, and here there are even less strict inclusion criteria. So you only need to be on the treatment for 3 years, and you only need to have MR4, so that's less than 0.01, for 1 year. So it's quite early and much less strict than the other 2 studies. The safety is equally as was done before, but now the testing has gone up to 6 weekly after the 6 months of treatment. And again, loss of the response is still loss of major molecular response. But no patient who was resistant to treatment was allowed to enter any of these studies. So again, optimally responding patients on standard doses of drug were included. So this shows the data from the Euroski study that was most recently presented, and we have changed our terms slightly. So we no longer call it relapse, we call it recurrence. The term treatment-free remission is also being lost because we don't like the word remission. So now we talk about molecular recurrence and treatment-free survival. But essentially, it's the same thing that we are looking at. So if you remember, patients only reintroduced their drugs when the PCR went above 0.1%. And even if you do it this way, with much less strict criteria, the number of patients that stay off their treatment long term is still 60%. If we look at who was able to stay off for longer, it seems that those patients that were treated with a TKI for longer, approaching 6 years, seem to do better. In this study, but not in all studies, a pre-treatment with interferon was beneficial, but the duration of the deep molecular response, so that is less than 0.01, that was found to be predictive, is 3 years. I look at the data from the Euroski, and I think this is very important. Although it was a trial, some patients were lost to follow-up within that trial. And a number of studies have also shown this, that even if you lose your hematological response, which is a very alarming situation to be in, because you have lost all your molecular response and there's been an increase in the blood cells, on reintroduction of the treatment, again, these patients seem to go back to where they were before. So that's loss, the worst loss you can think of apart from progression, which is hematological response, and also losing the cytogenetic response, which is complete cytogenetic response at greater than 1%. So Euroski looked at the duration of treatment and the duration of the deep molecular response, but this was also looked at in the very first study, which was STIM. And if you remember, you had to be 2 years deep molecular response, but 5 years seemed to be better than 2 years of a deep response, and 8 years was even better than 5 years. But of course, we have to make our recommendations on a practical basis, but we do bear this data in mind. The other fact that you may have heard of is prediction with statistics about how long you need to stay on the drug. And I think some of the doctors may have already been saying in clinic, because lots of our patients are coming to us to say, please, can we stop treatment as soon as possible? And certainly they are using this data which says that every year you are on treatment, the likelihood that you stay off treatment is increased every year by 16% up until those 5 years. So we're using the molecular and statistical analysis in order to guide us. Many studies, as you have seen, use different levels of molecular response, and some of the sponsored drug studies have used different depth of response. But what you can see is that there is no difference between MR4, MR4.5 or MR5. You just need to be under MR4 for a good enough deep molecular response in order to stop. So you don't need to wipe out every last molecule in order to do this, and less than MR4 is sufficient. Of course, it's not always completely wonderful in medicine, that we sometimes have to appreciate this. And some patients, after stopping, which was first found on the Euroski patients in the Nordic countries, developed quite significant muscular pain, which was mainly in their shoulders and their hips. It tended to happen 4 to 6 weeks after stopping the medication. Some of the musculoskeletal pain was bearable and settled with simple analgesia, but some patients had really quite severe pain that needed a course of steroids in order to get over these symptoms. For those patients that developed the pains in their joints and then went back on therapy because they lost their response, the pains went away again. We think the reason for this is the same off-target signaling that we spoke about yesterday. So you have suddenly released all those signaling pathways, they have become active, and this has caused inflammation because of reactivation, particularly of the c-KIT and PGF that we spoke about. It seems that these drugs are very good for joint pain in general, if you look at other trials, and they're also good for a number of other neurological conditions. So they have many other effects that we don't quite know about. But so far, the rate of the TKI withdrawal syndrome seems to be 30% in the Nordic countries, but for other centres it ranges between 10 and 20%. But if you remember, this is also on trial. In the UK, being the UK, we didn't want to do what everyone else was doing, so we decided to take a different approach. And this was to use, again, very good responding patients, no resistant patients, no patient on a higher dose of the drug, treated for 3 years as a minimum, and if the patients were in major molecular response, so that's less than 0.1%, the dose of the drug was halved. So we had mainly imatinib-treated patients. Around 80% were treated with imatinib, and the rest with dasatinib and nilotinib. So you know that we have great confidence in half-dose nilotinib and dasatinib, but we weren't sure at all about the 200 milligram imatinib dose, whether it's any different to not taking any at all. And our other colleagues in Europe and America were very worried about halving the dose of imatinib to 200, because in the laboratory it's found to breed resistance and mutations. But we haven't seen anything like that in the clinic. So that was the approach of the Destiny study, and last year we presented the halving data, so going from imatinib 400 to 200 for 2 groups of patients, less than 0.1%, which is major molecular response, and then deeper responses, less than 0.01%, which is MR4. So you can see something that we suspected in the clinic anyway, but as John Goldman said to me, if you don't do the trial, you will never get the real answer to the question. And if you half the dose from standard to 50% of certainly imatinib, things don't go as well as you would expect if you're doing the same with a deeper response. So the patients did relapse if they were halved in major molecular response, but only around 20%, which is quite surprising because we thought that more would lose their major molecular response. The deeper group did a lot better, but we would, of course, expect that. So this shows the maintenance of response after halving the dose of the drug. After we halved the dose of the drug, we then went on to stop the drug completely. So obviously, this was of a concern in patients who were in, again, major molecular response, but not so much of a worry if you were deeper than that on 50% of the drug. What you can see here is the results of the Euroski study. I said that 60% of patients managed to stay off. But if you look at the UK Destiny study, we have some quite outstanding and remarkable results, much higher rates of staying off the drug if you halved the dose before you stopped. This shows the patients that stopped in major molecular response, so stopping in less than 0.1%, and it is, as we suspect in the clinic, not a good idea to do this because this is the outcome. So why are we better than Euroski, having halved the dose? Is there something particular about the PCR? This may explain why the centres that were included in Euroski are quite a few, 61 sites in 11 countries, with many different PCR labs being used, whereas for the Destiny study, we only used the Hammersmith lab, so we had consistency for all of the patients' PCRs. The other question that could be addressed is that patients who are less than 0.1 can still be very deep, so they may be at the higher level of the 0.1. They might be 0.09, and they could also be 0.02. So it looks as many of these major molecular responding patients were in fact more approaching a deeper set, which is why that explains that the findings about stopping in MMR are not as bad as we anticipated. So it may be that these very sensitive levels of response don't translate in the Euroski study because of the different sites that were used. Lastly, we may be selecting out the best group of patients, patients who are managing to still have their CML under control with only 200 milligrams. Looking to the other drugs, so this is a stopping of a second generation drug. The majority of these patients were not used in case of resistance, but some of the patients were resistant to imatinib and then treated with a second generation drug. Similar frequency of monitoring. And you can again see that if you have been resistant before, then the likelihood of staying off treatment is not as good as if you are a sensitive patient. It looks very clearly that the choice of drug, the choice of TKI does not matter. It's the depth of response on the treatment. The rate of continuing off therapy is independent of the choice of treatment. It relies on the depth of response and the duration of response. If you have lost your response and then restarted drug, and then you want to try again if you've had a deep response, will this be successful? And this shows some data presented at ASH that not all is lost if you've had an unsuccessful discontinuation, and that a second attempt may be successful in the future. So it's something to look at the data and keep carefully observing the patients. Is it safe to do? In nearly all of our cases, patients have responded to the treatment. The majority will regain their deep response within 6 months. 80% of patients will go on to regain the response. And because we can't say 100%, it's because the studies are still ongoing and the patients still have their level falling. We have forgotten that it does take 3 months for the drugs to work. You wouldn't have expected in 3 months suddenly go to zero. It's the same again when you reintroduce the drug. Sometimes the PCR goes up until it falls again. So it's just to be reassuring. So we used to say, don't do this at home, don't stop, wait for the next clinical trial, be patient. But now we've had many patients come to us complaining of side effects, unable to function. We look at their responses and we say, look at the data, why don't we try and stop? Many patients know about this, and again, we look at the data that we have so far, and we work together with the patient to try and get the best outcome if patients want to discontinue therapy for whatever reason. So it is an agreement, and there have been some recommendations written by the American guideline group, the NCCN. They're very focused on safety, and of course they are written before the final outcome of the Euroski study and before the Destiny study. But you have to be in chronic phase. This is not for anyone who's in advanced phase. It would be more likely accelerated phase. The recommendation is treatment with a TKI for 3 years, but you and your doctor will be more comfortable if you've had treatment for 5 years if you look at the predictive factors. You have to know what you are monitoring at a very low level. So some patients will just have had bone marrows and not had their molecular signature for the BCR-ABL type at diagnosis. And it's really important to know what you are looking for in case you have a rare transcript. Your lab may not be able to pick this up, and the only way you will find out if you lose your blood response. So this is really important. You have to be monitored in a very good lab, and they have to be able to detect low levels of disease. You can't be resistant, you can't have a mutation. You've seen the data, it's likely that you will relapse. We need to have a lab that is able to provide the results very quickly. So if patients are coming every 4 weeks, there is no point in having a test where the lab will only provide this result in 4 and 6 weeks. So the guidelines usually are that the PCR is tested in a lab that can turn these results around in 14 days. We still say monthly for the first 6 months, then 6 weekly for years, month 7 to 12, then 2 monthly year 2, 3 monthly forevermore. You cannot be discharged. And in the Italian group of patients that were treated off study, there have been some late relapses at 5 years and also in Asia. So we still have to be vigilant. You should discuss this with a CML specialist. You don't have to be monitored and treated in the CML center, but the whole approach needs to be sanctioned by a CML specialist. You have to be prepared to come to the hospital every month. A lot of patients that come every 3 to 6 months find this difficult to position in their work life, but it is really critical. And then after the PCR goes up, the standard or the maximum tolerated dose needs to be restarted. We shouldn't really restart on a lower dose because we end up chasing the PCR and then increasing the dose quite regularly, which alarms both the doctor and the patient. If the result hasn't fallen, then a mutation test needs to be back and done, and we need to make sure that all our patients go back to where they were before. So it is an agreement. We have to work together to do that, but we can have very good successes. So I don't know if we'll take questions after the presentation.